Alright guys, here we are now looking at puerperium, which is the last topic for CK obstetrics, and then we'll be able to move forward onto gynecology, which is a lot more straightforward in the sense that it's a little more step one related topics, not exactly all entirely CK brand new stuff. So puerperium normal changes after delivery include transient fever and chills, lochia, which is vaginal discharge, uterine contractions, and uterine involution. Postpartum urinary retention is also common and caused by bladder atony. This can be managed with catheterization and encouragement of ambulation and usually resolves spontaneously. Radiating suprapubic pain exacerbated by weight bearing may also occur because of diastasis of the pubic symphyses, right? Because it really opened up a lot. This is more common following a traumatic delivery, and treatment is with supportive care. So as you can see, none of this should be very concerning. Some of these are just normal things, but then come things that are still concerning. So number one, we have here postpartum hemorrhage. As we saw back in step one, hemorrhage even during delivery was already bad enough. That was pretty bad news, scary stuff. And then postpartum hemorrhage, the mom can actually just die of hemorrhage. One of the most concerning things about hemorrhage related to delivery was Shian Syndrome, where you lost so much blood you didn't get enough blood supply to your pituitary, and then your pituitary died. So a loss of more than 1,000 milliliters, irrespective of the type of delivery, may occur before, during, or after delivery of the placenta. And they have the table here to talk about it. Right, so differential diagnosis of postpartum hemorrhage: uterine atony, right, retained products of conception, and then genital tract trauma. And then UWorld had one additional one, inherited coagulopathy, which of course makes sense. So UWorld here is showing you the combination of how things can be tested from obstetrics and hem-onc, more about the coagulation aspect, right? So you have to know that, because you see UWorld is actually showing you how things on tests can be confusing. You could have a patient who is bleeding, and it's not just because of the delivery part, but mainly because they have a coagulopathy, which means they would probably have a history, and that's what they're telling you in the table, right? That if the bleeding that this patient is having isn't just because of the delivery right now and some complication related to delivery right now, then they must have a history of bleeding if it's an inherited coagulopathy that you've had all your life, right? So the real risk factor is going to be history of abnormal bleeding in the patient or even family members. And there's going to be continued bleeding despite contraction of the uterus, right? What we really want usually when we're treating most of these things are uterotonic medications that are going to cause contraction, so that when the muscles contract, they're going to squeeze the blood vessels and then bleeding is going to stop. Here, even the contraction won't stop the bleeding, right? And then you'll realize that the only way to fix it is to correct the coagulopathy. If they're missing factors, give it to them, stuff like that. So that's one of the extra topics that UWorld is talking about, which is a combination topic coming from hematology. The other things, uterine atony, retained products of conception, and genital tract trauma, are always going to be very obvious questions. But remember, I always say this, but things only become obvious when you're first aware that these things even exist. So you need to make sure you understand they exist, and once you see the scenario in a question, it'll be even more obvious. So first one, uterine atony. Prolonged labor, chorioamnionitis, uterine overdistension, and many other things are huge risk factors for uterine losing its tone. That's what atony means. There's no muscle tone in the uterine area, so the uterus has no tone, and then of course it's not going to stop bleeding. So if something doesn't flex, right, if it doesn't stay nice and tight, then it stretches out. So of course examination is going to give you an enlarged boggy uterus, right? And the management here is going to involve a bimanual uterine massage along with uterotonic medications that will increase uterine tone, right? So that's the key aspect of treating all of that. The other thing here, we have retained products of conception, succenturate placenta, manual extraction of the placenta, or history of previous uterine surgery, all cause different kinds of risk factors for retained products of conception. So now anytime a patient has retained products of conception, it's almost always questions where the pregnancy wasn't successful, so there was some sort of abortion that was necessary. Remember that they tell you irrespective of type of delivery. So even if it was a failed delivery, an aborted delivery, those are all also going to count. Either way, even if it was a successful delivery, if the placenta didn't all come out, there has to be reasons for that. Sometimes it can also be one of the other reasons we looked at earlier, which was the placenta accreta, right, or increta, where it's actually attached stronger than usual. So when you pull out the placenta, maybe it did detach, but then not all of it, right? You thought you got it all out, but not all of it came out. So then again, you get this enlarged boggy uterus, placenta missing cotyledons, and retained placental fragments on ultrasound. So now to find some pictures for these things, let me show you what they're talking about. So placental cotyledons. So what they're talking about in terms of the cotyledons, let me see where I can find a good picture of it. Yeah, they're not really. Oh, here we go. Okay, this is kind of sort of nice. Let's put it here. So in this picture, you can see the maternal surface of the placenta. So this is the part of the placenta that's attached to the mom, right? This is the fetal surface of the placenta. So the cotyledon is just that part that's supposed to attach to the mom. That some of it didn't come out. If you wanted to get a better view of it, then you'd be basically looking at this. Right, so this part deep inside that goes inside the maternal surface, this stuff are the cotyledons, right? Which mainly is encompassed with the umbilical veins and arteries, right? So this stuff, if it got retained inside the mom, that means you didn't get it all out, right? All of it needs to come out, at which point all you really have left there is just the uterus. And succenturiate placenta. Wow, the word almost entirely typed itself up in Google as if it heard me talking. So let's see, let me find you a good picture of that. This thing. So basically what succenturiate placenta is, it's kind of like having two placenta in a sense. It's really weird, right? So you can see here, this is the main placenta, this is the extra one, and they're both attached to the mom. And they're both going to be, of course, supplying the fetus. But when you don't realize that this has occurred, because of course the whole thing is also connected by one big mass, if you don't realize this occurred and then you, get the baby out, but leave the placenta, then that causes a problem, right? Because then you might have taken out the main placenta, but not the other one. So that's what a succenturiate placenta is. That's all those topics are about. And if you didn't know those topics, and anytime you see these words in a table or any part of the book, really, you should look them up. Find more images, find more pictures, get a good understanding of what's actually happening. So here in their own table, uterine atony, uterine overdistension. If you stretch it out too much for whatever reason, multiple gestation, big head of the baby, or big baby in general, right? Like in gestational diabetic babies, and then polyhydramnios, all these are case scenarios where we're going to stretch it out too much and then the muscle loses its tone. So you get an exhausted myometrium, right? Rapid or prolonged labor, oxytocin stimulation, any of these things can also cause an exhausted myometrium. And uterine infection, that can also cause the uterine muscles to lose tone. And then conditions interfering with contractions, such as anesthesia, which I told you guys to always watch out for in these pregnancy questions, especially if it was epidural anesthesia, because then you can get a spinal abscess. Myomas, or even magnesium sulfate, which mainly we use for two things, right? One was the eclampsia, and two, because it'll help fetal neural tube development, fetal brain development. So diagnosis of uterine atony is palpation of a soft, enlarged. 3 more days until Ramadan's over, guys. Soft, enlarged, boggy uterus, because there's no tone, so it's just nice and stretchy and wobbly. Most common cause of postpartum hemorrhage. This is the most common cause of postpartum hemorrhage. And it really is. And thank God this is the most common cause and not one of the other things, because this is also very easy to deal with. As you can see, just do a bimanual uterine massage and it's usually successful. That's all you have to do. So that should be, remember, you always want to avoid medications as much as possible. And most of these questions about uterine atony are going to have all these as answer choices. So you want to pick bimanual uterine massage as long as it really sounds like that's all the patient's going to need and the patient's not in any really bad condition. Oxytocin infusion, methergine, and PGF2 alpha are also answer choices. This answer choice, methylgarnovine, you just have to be very careful not to give it if they are hypertensive. If they have hypertension after delivery, which can occur, then you don't want to give this. Right? That's really all there is here. I also have an extra note from a question we're going to be looking at. If atony persists after the massage and oxytocin, the next best step is to administer tranexamic acid, which they didn't write in the book. an antifibrinolytic that achieves hemostasis. If that also doesn't work, second line is to go to uterotonics like carboprost-tromethamine, a prostaglandin analog that increases uterine contractility but can also cause bronchospasms. So you avoid that in asthma. That's this thing right here, right? So the PGF2 alpha you have to avoid in asthma, and the methotrexate you have to avoid in hypertension. So you can see how these questions can definitely start becoming something very confusing soon enough. So if you have a pregnant woman who has a history of hypertension, you're always going to be highlighting that, like I've been underlining it in all the practice questions we do. If you have a pregnant woman with asthma, of course you'll be highlighting that, just like I underline anything critical like that in the practice sessions we do. So stuff like that is going to be pretty critical, but here are some more answer choices that you may have to pick based off of what's happening. So why would you have to pick tranexamic acid? Well, in your question, they might have already told you that they did the uterine massage, they did the oxytocin, and it still didn't work. So then after that, tranexamic acid is the thing to do to get hemostasis, right? And after that, a uterotonic like carboprost is the thing, right? So tranexamic acid and carboprost are not something that go in order though, so you can just go to carboprost as well if tranexamic acid is not an answer choice. Just pick the carboprost, right? Next thing, genital tract trauma. So this can occur due to precipitous labor, operative vaginal delivery like with forceps or vacuum assisted, a large infant, which once again related to gestational diabetes, or inadequate episiotomy repair. We talked about episiotomy last time, which was just a surgical extension of the vaginal opening into the perineum. You just make a little incision to make the opening bigger. If you make the opening bigger, you have to close the opening as well. So if you do these things, these are going to be trauma issues that are going to cause postpartum hemorrhage. So how do you diagnose this? Well, you're going to see manual and visual inspection of the lower genital tract for any laceration of more than 2 centimeters. You're going to search for this and you'll find it. And if you find it, then of course the easy answer here is just to surgically correct it. That's it. So this is a very easy one. You see, so if you're going to get a question on one of these three, it'll probably be the first one. Not only because it's the most common one, but also because it's got a lot of things you could test someone on. The last thing here, the retained placental tissue. So this can occur again, placenta accreta, increta, percreta, where the placenta is literally strongly just attached to the mom. Placenta previa, where you never really did take out the placenta because you probably did a C-section delivery. So now you need to actually make sure you get the placenta out. But since the placenta is attached in a weird area, some of it might get left over. Uterine leiomyomas, preterm delivery, and previous C-section or curettage, right? All of which are also smaller reasons that retained placental tissue can occur, but definitely a reason nonetheless. So how do you diagnose this? You check. You go in and you look for placenta and uterine cavity for missing cotyledons. If you look at the placenta you took out and you see a tiny portion of it is missing a cotyledon, then that cotyledon must have been left inside the mom, right? And then if you look inside the uterine cavity, you might find that cotyledon and you get it out. Ultrasound may also be used to inspect the uterus. How do you fix this? As we said, just get it out. Whatever's left, you take it out. Right? Very straightforward. So these two last ones are super straightforward with a very direct solution for fixing the problem. Right? So nothing much more to say about that part. Righty. Good. So coming back to this. Next page, complications, acute blood loss, potentially fatal, anemia caused by chronic blood loss, predisposes to puerperal infection, and Shian Syndrome, as we just talked about earlier. So these are some things that you're going to have to be very careful with. The other two topics they have for postpartum hemorrhage, they've got uterine inversion and uterine rupture, like this, which looks like it's from like a horror movie or something. Uterine inversion, the whole uterus, right, it's very uncommon for this to occur. So an uncommon cause of postpartum hemorrhage. This occurs when the uterine fundus prolapses through the cervix and vagina and can often be visible as a smooth mass protruding from the vagina. Treatment involves manually replacing the uterus and monitoring hemodynamic status. So very straightforward topic once again. Same thing here. This is also pretty straightforward. Very rare but life-threatening complication that may occur in women with a history of multiple uterine surgeries. Loss of fetal station is pathognomonic for this condition, and fetal parts may be palpable in the abdomen but not in the vagina. Treatment involves emergent laparotomy, right? So of course you can palpate this over the mom's belly, but when you do a cervical exam, a digital cervical exam, you might not really feel much of the baby's head. That's what they mean by loss of fetal station. So remember, the fetal station went from -2 deep inside the mom to 0, and then the +3 coming out of the mom. So the fetus should be descending out of the mom. If there's another opening that it can come out of, then instead of descending out of the mom's vagina, it's just gonna go that way, as you can see. Right? This is also related to another topic we looked at yesterday, which was the classical cesarean delivery. Remember, and I wrote that note here. So uterine rupture risk is greatest in patients with prior classical cesarean delivery or a prior myomectomy. So classical delivery was done in this manner, in which case if you ever did a classical delivery for a mom, you probably have to continue doing C-section for the mom for the rest of her life, because if this mom tries to now do, imagine a woman who got a classical delivery before, got this exact incision to take the baby out, and her next pregnancy, if she tries to do a vaginal delivery, the pressure that builds up from contractions and everything else can actually cause this exact uterine rupture to occur, which is why you wouldn't do vaginal delivery for that mom ever after that C-section, after this classical cesarean delivery. Next thing here, postpartum infection, right? A temperature of more than 38 degrees Celsius for at least 2 of the first 10 postpartum days, not including the first 24 hours. Oh my god. The risk factors for postpartum endometritis include emergent C-section, prolonged labor, multiple intrapartum vaginal exams, intrauterine manipulations, delivery, low SES, young age, many things. There's a lot of things that can cause postpartum endometritis, right? So you're looking for this. This is the main postpartum infection you're trying to work with. Treatment, broad spectrum empiric IV antibiotics like clindamycin and gentamicin until patients have been afebrile for 48 hours. Add ampicillin for complicated cases. So this is going to be another answer choice where maybe you've already done the clindamycin, gentamicin, things are getting a little more worse. Ampicillin, right? Complications, of course, if you don't deal with it, you can get septic pelvic thrombophlebitis. Pelvic infection leads to infection of the vein wall and intimal damage, leading in turn to thrombogenesis. The clot is then invaded by microorganisms. Separation follows with liquefaction, fragmentation, and finally septic embolization. Presents with abdominal and back pain and a picket fence fever curve, with wide swings from normal to as high as 41 degrees Celsius that is unresponsive to antibiotics. Diagnosed with blood cultures and CT looking for a pelvic abscess. Treat with broad spectrum antibiotics and anticoagulation with heparin for 7 to 10 days. Right. So this is just generally how you would deal with the thrombophlebitis to begin with. Not the most weird scenario. Just weird because it's occurring, in a woman who just delivered. Like you thought she would be at more peace now, and here she is having infection and stuff. So it's always a big bother. This is really, really annoying for these moms. On the left, we have the tables for uterine rupture and postpartum uterine atony, just to get more of the information. So you can see the tranexamic acid, carboprost. There's also balloon tamponade, possible surgical intervention. There's a lot of answer choices for that, as you can tell. Really big intervention. Right? Management is one line here, and management here is a bunch of dots. Right? So definitely one of the most tested topics, or most testable topics of the three, and then this one, right? Inherited coagulopathy. Next thing, Shian Syndrome, postpartum pituitary necrosis. Pituitary ischemia and necrosis that leads to anterior pituitary insufficiency secondary to massive obstetric hemorrhage and shock. The primary cause of anterior pituitary insufficiency in adult females. The most common presenting syndrome is failure to lactate, right? Because you lost your anterior pituitary. So that's it. Other symptoms include weakness, lethargy, cold intolerance, genital atrophy, and menstrual disorders because of all the things that come off the anterior pituitary. Diagnosis, provocative hormonal testing. That's the best initial test. So you're basically checking for the hormones that the pituitary is supposed to make, and you may not see some of them, right? Most accurate test is to, of course, look at the pituitary itself, and you'll know that it's necrosing because of hemorrhage. So you do the MRI of the pituitary. And treatment is to just replace whatever hormones are no longer being made. So at least treatment-wise, it's definitely very much feasible. Some patients may recover TSH and even gonadotropin function after cortisol replacement alone, right? So again, this all just, it's that last sentence is pretty experimental. I would just really just pick the answer choice of replacing whatever hormone is missing. That's the easiest, the standard way of fixing that problem. Next thing here, lactation and breastfeeding. So during pregnancy, high estrogen and progesterone result in breast hypertrophy and inhibition of the action of prolactin on the breast. Mainly progestation, progesterone, just keeps you pregnant, and if you're pregnant, you should not have prolactation. You should not be lactating. So the two balance each other off very well. After delivery of the placenta, hormone levels markedly decrease, and prolactin stimulates the alveolar epithelial cells, activating milk production. Higher prolactin will decrease LH and FSH, causing anovulation and amenorrhea during breastfeeding. So you can see how lactation, and generally even breastfeeding, is a sense of autoimmunity from getting pregnant. Right? So it's like a naturally built-in birth control in a sense. So anovulation and amenorrhea during breastfeeding. So you should continue breastfeeding. That's also good for the mom because that's lesser irritation of the ovaries of the mom, right? So you don't want this kind of bad irritation. Next thing, colostrum. Early breast milk, the colostrum, contains protein, fat, secretory IgA, and many things that the baby can really benefit from now that it's being born. Within 1 week postpartum, mature milk with protein, fat, lactose, and water is produced. High IgA levels in the colostrum provide passive immunity for the infant and protect against enteric bacteria, which is why anytime in my pediatrics department when a parent would come in saying they are breastfeeding, my attending physician would be very happy about that because it's good for the baby and it's good for the mom, so there's really no reason not to. Other potential benefits include the following: decreased incidence of infant allergies, decreased incidence of early upper respiratory infections, upper respiratory infections or GI infections, facilitation of mother-child bonding, and maternal weight loss. So all of these are great reasons to be breastfeeding after delivering a baby. Contraindications to breastfeeding include HIV infection after drug use, including marijuana, and use of certain medications like tetracyclines and chloramphenicol. Tetracyclines cause the yellow teeth. Chloramphenicol causes the gray baby syndrome. Women who desire to suppress lactation should wear a supportive bra, avoid nipple stimulation, apply ice packs to the breast, and use NSAIDs to reduce pain. All of which are different answer choices you're going to have to be very comfortable picking if they're ever talking about something to do with breasts, right? Whether it's using it in this manner or breast pain or breast cancer, any of these things, these are all going to be very critical. So here, women who desire to suppress lactation, the question and answer choices might include supportive bra in there. You have to make sure you pick that, right? Because the supportive bra would prevent nipple stimulation, and without nipple stimulation, your money can't really be moved, right? Because there's no fan base without the mom actually being satisfied, right? Last thing on this page is mastitis, like cellulitis of the periglandular tissue caused by nipple trauma from breastfeeding, mainly when the baby bites into it, right? Bites into the nipple. So that then introduces bacteria like Staph aureus from the infant's pharynx into the nipple's ducts. Symptoms begin 2 to 4 weeks postpartum, are usually unilateral, and include the following. So you have to take, all of this into account with the patient. Breast tenderness, erythema, edema, warmth, and possible prelude nipple discharge. Significant fever, chills, and malaise can also be seen. So, of course, this entire time the mom has already, of course, been breastfeeding. You would stop that until she recovers first. Get the mastitis recovered, then continue with the baby. Differentiate from simple breast swelling. Infection is suggested by focal symptoms in high white blood cell count and fever. Right, so it's not this infection one, so we're going to have to figure out what's up with that, right? Treatment: continued breastfeeding to prevent the accumulation of infected material or use of a breast pump in patients who are no longer breastfeeding. PO antibiotics. If no clinical improvement within 48 to 72 hours, evaluate with breast ultrasonography to assess for abscess. If present, treat with incision and drainage. All right. So that's it for all of that, and we're done with obstetrics. So let's take a look at some of these questions now. We got this first one up here. 30-year-old woman, G1P0. Alright, so it's her first pregnancy, admitted to the hospital in active labor, so her cervix must be dilated more than 6 centimeters, and undergoes a forceps-assisted vaginal delivery due to recurrent late fetal heart rate decelerations. She delivers a 9.3-pound infant with APGAR scores that are good. Hour after delivery, she feels dizzy and lightheaded, no chest pain or shortness of breath, and has had no focal loss of consciousness. Blood pressure is very low, 90 over 50. Pulse is high, 120. She appears pale and diaphoretic. Cardiac exam shows sinus tachycardia, but no rubs or murmurs. So her heart rate is just up, which we know. Pulse is 120. The lungs are clear to auscultation. Uterus is firm, non-tender, and palpable at the umbilicus. On pelvic exam, there is minimal blood on the perineal pad. A large purple mass protrudes medially into the vagina. What is the most likely diagnosis in this patient? So the answer was vaginal hematoma. 50% of people picked it, but 20% chose retained placenta, or 25% chose uterine inversion, which are all completely, there's just no reason to have them. You know, they're the bad answer choices. Her hypovolemic shock and protruding vaginal mass are most likely due to a vaginal hematoma, a potentially life-threatening postpartum complication. During delivery, stretching of the vaginal canal can injure the uterine artery, particularly in nulliparous patients doing operative vaginal delivery. Right, so the forceps assisted stuff is always going to have a bunch of answer choices where something like this occurs. Later on, we're going to see a cephalohematoma as well. So the baby gets a little bit of a hematoma right here. There's going to be subgallio veins and subperiosteal bleeding, all kinds of answer choices that we're going to see sometime in pediatrics. But with her, you know, the resultant injury from the forceps assisted delivery can cause massive postpartum bleeding, as the uterine artery during pregnancy enlarges and supplies the uterus with up to 30% of total cardiac output. Because the blood collects in the paravaginal space, patients often have massive occult bleeding, evidenced by the hypovolemic shock, and her iron hopefully is going to come back normal if you were to order something like that, right? Hematomas are managed based on hemodynamic stability, right, and whether they can continue to expand. Because if they can continue to expand, you need to stop it right away and do the surgical intervention. Non-expanding hematomas are observed, whereas expanding hematomas are going to require arterial embolization or surgery. So there's going to be another answer choice you're going to have to pick between what to do and what not to do. Right? So that's it for that. In the next video, we'll wrap up the list of practice questions over here and dive right into gynecology.